things off now. Welcome to the September Valleywise Grand Rounds. We're very excited to welcome Dr. Seserinac to discuss diagnostic errors with us today. Now, first, for the usual housekeeping, please make sure to put yourself on mute, and then midway through, Megan will be putting the CME code in the chat. This has come up the last few times. Please remember that this is through the Creighton CME, so if you are texting, you need to text the word attend and then the code, or you can go to the Creighton CME website. Now, back to the business of the day. Dr. Seserinac is part of our hospitalist team here at Valleywise and is highly involved with the AAP, both serving on the Society to Improve Diagnosis and then also very active in the hospital medicine arena, starting with the Strategic Planning Certification Group, then on to Evidence-Based Medicine, the Educational Task Force, and she's now on the PrEP editorial board. She's worked closely with residents and medical students throughout her career by mentoring, formal lectures, and bedside learning. Now, one area of passion for Dr. Seserinac is diagnostic errors in medicine, and we're glad to have her with us this morning to discuss how we can identify and then be able to minimize them in our practice. I will hand it over to you.
Hello, everyone. Good morning. I got interested in diagnostic errors after I heard a talk at AAP meeting about diagnostic errors. And at that time, in 2015, new report by National Academy of Medicine, Improving Diagnosis in Healthcare. After that, I went to Diagnostic Error Medicine conference given by Society for Improvement Diagnosis in Medicine, and really liked it and went several more times and found this topic very interesting. I'm hoping to shed some light on diagnostic errors, how and why they happen, impact on healthcare, some specific issues that we pediatricians face, with emphasizing on what can we do about it and how to make it better. So how big of a deal are diagnostic error in medicine? 1 in 3 of all malpractice cases that result in death and permanent disability originate from an inaccurate and delayed diagnosis. Diagnostic errors are the #1 cause of serious harms among all medical errors, with the highest total penalty payout. To convince you further, another number to remember is 12,000 millions, which is an estimated number of Americans affected by diagnostic errors each year. Those may seriously harm 1/3 of those people. Diagnostic errors contribute to as many as 70% of all medical errors. Another number to remember is 80,000. Roughly 80,000 report goes between 40,000 and 100,000 deaths in United States. Hospitals each year can be contributed to diagnostic error. It's about the same number of people who die annually from breast cancer and diabetes. To further convince you, let's go through some more numbers. It's said that every 9 minutes, someone dies due to wrong or delayed medical diagnosis. 1 in 10 diagnoses are incorrect. Major diagnostic errors are found in 10 to 20% of autopsies. 1 in 20 primary care patients will experience a diagnostic error every year. And diagnostic errors occur in around 10 to 15% of all the encounters. So, year 2015 was a groundbreaking year for diagnostic error. At that time, National Academy of Science, Engineering, and Medicine issued a report improving diagnosis in healthcare, which states that it is likely that most of us will experience at least 1 diagnostic error in our lifetime, sometimes with devastating consequences. It is quite a sobering statement. Diagnostic errors are common, costly, and harmful. How are we doing in pediatrics? A multicenter study in pediatrics did a survey of pediatricians and found that 54% of pediatricians and around 77% of pediatric trainees reported at least 1 to 2 diagnostic errors per month. Those were mainly viral illnesses mistaken for bacterial, missing the diagnosis of hypertension, delaying diagnosis secondary to missed subspecialty referrals, or delaying follow-up of abnormal lab test results. 45% of pediatricians reported diagnostic error that harmed patient at least 1 to 2 times per year. And most of the diagnoses were misdiagnosis of medication side effect, psychiatric disorders, especially a presence of suicidal ideation, abdominal pain turning out to be appendicitis. Another study looked at systemic review of autopsies in pediatric and neonatal ICUs and found that potentially lethal diagnostic errors were found at 6.4% deaths in PICU and 3.7% deaths in NICU. Those are class 1 error per Goldman classification of autopsy finding, meaning that the major diagnoses were missed, in which detections before that may have altered management and patient outcome. Most commonly, misdiagnoses were infection and vascular events. Another study reviewed the morbidity and mortality conferences over 14 months at Johns Hopkins hospitals and showed that 21% of patients had diagnostic errors. Almost all diagnostic errors could have had impact on patient survival and safety. 50% of those errors were preventable, and 25% of diagnostic error produced harm that contributed to death. Contributing factor to those diagnostic errors were 40% were found to be systemic failure, 20% were cognitive factors, and 35% of those errors were found to be due to combined factors. I already mentioned the National Academy of Science, Engineering, and Medicine 215-year initiative. And that's when they came up to the report that talked about state of diagnosis in medicine. The first report that addressed errors in medicine was in 2000. In year 2000, which is to err is human. And in that report, the procedures and medication errors were mentioned more than 70 times, while diagnostic errors were mentioned only 2 times. This new report is improved. New report, 2015 report was called Improving Diagnosis in Healthcare. How come that it took around 15 years from the first emphasis on errors in medicine to realize that we as healthcare workers are not so great and infallible in the area of diagnosis? Is it just a purposeful lack of attention, ignorance, or something more that took 15 years to address diagnostic error more thoroughly? So the problem is that we know that diagnostic and clinical reasoning processes and biases are very difficult to understand. There is cultural attitude that discourages discussion about diagnostic error. Physicians are not aware of the problem, and there is minimal or no feedback on diagnostic performance. There is stigma, guilt, fear involved, and culture of safety was not quite well developed at the beginning of 2000s. There are difficulties in defining and studying diagnostic errors. Measuring diagnostic quality is impractical, and diagnostic errors are in general less amenable to system-level solution. So what has changed? Advances in health information technology allow better tracking, measuring, and reducing diagnostic error. Also, we got much better in preventing procedural and medication errors, which was emphasis of report in 2000. Next, physicians and researchers realized that diagnostic errors are clinically and financially more costly today than ever before. The treatment options are becoming more effective and costly. Thus, misdiagnosis of readily treatable conditions is devastating. So think about this, like mortality of severe myocardial infarction in past was around 30%, but while nowadays the same condition mortality is around 5%. Before there was no treatment for colon cancer stage 4. Today we can treat it. However, the treatment is much more costly than if it was diagnosed in stage 1. Before, the treatment options for pulmonary embolism, strokes were minimal, while today we can do much about it. It can be successfully treated, which is very specifically interesting for pediatrics because it's quite rare and can be missed easily. Another thing specifically for pediatrics, nowadays we can treat with gene therapy many metabolic and genetic diseases like SMA, even cystic fibrosis, sickle cell disease. So missing those diagnoses is really devastating. It is significantly affecting healthcare, leading to high clinical costs for patient life and quality of life, and also significant financial costs with the waste of healthcare resources. Also, pay for performance metrics and risk-based contracts created environments when accurate and timely diagnosis could be rewarded. Another aspect of diagnostic error is that fact that the world is interconnected. Misdiagnosis could affect many others. Missing virulent communicable disease, large public health implications. Remember successes of Ebola 2014 and pure disasters of COVID-19 in 2020. Another issue is regard to mental health problem. While missing diagnosis of homicidal violence, it has a potential effect on many others that patient will get in contact with that can lead to murders and mass murders. So how do we study diagnostic errors? We use autopsies, chart reviews, malpractice claims, morbidity, mortality conferences, physician self-report, patient report. Then we can look at unplanned repeated visits to emergency department, readmissions to the ward, transfer to the pediatric intensive care unit, rapid response calls, code blue reviews, and with development of electronic health records, we can use all those as a trigger tools. There was a recent study that, for example, used a trigger tool, a symptom, abdominal pain, combined with repeat to emergency department within 2 weeks, and thus looked at appendicitis as a misdiagnosis. So now that we all agree that about the impact of diagnostic error, we need to define and how we think about the diagnosis. So what is diagnosis? Diagnosis is a set of pre-existing categories agreed upon by medical profession to designate specific condition. Diagnostic process is the process of integrating patient symptoms to categorize the underlying disease and guide treatment. Getting to the right diagnosis is a key aspect of healthcare. Diagnostic process is the most difficult cognitive challenge that exists in medicine due to its complexity, variability, and uncertainty. Diagnosis is a hypothesis, and as a diagnostic process unfolds, clinicians' confidence is adjusted in either directions by gathering and analyzing data that argue for or against that hypothesis. The goal of clinical decision-making process is to correctly understand patients' health problem. Formulating an accurate diagnosis in a timely manner that provides an explanation of patient health problem gives us the best opportunity for successful treatment and for a positive outcome. This is all exceedingly difficult and dynamic process. That final conclusion gets adjusted based on new data gathered through the process. Still, how do we define the correct diagnosis? We need to know what's the correct diagnosis, definition of correct diagnosis, to be able to address diagnostic errors. So prior to National Academy of Medicine report in 2015, we looked at diagnosis in these terms: misdiagnosis, wrong diagnosis, and delayed diagnosis. With misdiagnosis, we said no diagnoses were ever made, medical complaints were never explained. Wrong diagnosis was made when another diagnosis came before the correct one, or delayed diagnosis. We could have made diagnosis based on gathered information. Sufficient information was available. So National Academy in their report redefined diagnostic errors. In the report Improving Diagnosis in Healthcare, diagnostic error is defined as a failure to establish an accurate and timely explanation of patient's health problem, and failure to communicate that explanation to the patient. This definition perfectly aligns with the 6 goals for quality care, which is effectiveness, efficiency, timeliness, patient-centeredness, safety, and equity. So if we apply those 6 goals to this definition, we have that diagnostic errors is a failure to establish an accurate, addressing effectiveness, and timely, addressing efficiency and timeliness, explanation of patient's health problem, and failure to communicate, addressing patient-centeredness and safety, that explanation to the patient, addressing equity. So how do we get to the specific diagnosis? As the physicians evaluate the patients and learn about their medical problem, a diagnostic process happens in the physician mind. This is multifaceted and complex process that frequently needs to happen very quickly. Throughout the diagnostic process, physicians are applying their cognitive skills, knowledge, experience to diagnose and treat the patient. The key aspect of healthcare, everything that we do, is to get to the right diagnosis so that we can apply the correct treatment. Getting to the correct diagnosis is a process that takes place within a complex environment and influenced by many actors and factors. And it is the most complex and difficult cognitive challenge that we face due to complexity, variability, and uncertainty. So National Academy tried to explain this diagnostic process, creating this quite complicated graph, but it's actually relatively simple. As the patient develops a health problem and interacts with health system, And the diagnostic process starts with information gathering, information integration, interpretation, working diagnosis is created, that's communicated to the patient, treatment is started, and that can be accurate and timely diagnosis, or it can be near miss or diagnostic error. And that can positively or negatively affect the patient outcome. It also affects the system, its quality, its safety, its cost, its morale, public confidence in healthcare system. And we all learn from everything that happened, and it pulls the feedback onto that diagnostic process. So if still not convinced, I'm sorry, that getting to the diagnosis is complex, let's think about complexity of medicine. Nowadays, we have more than 30,000 diseases, syndromes, and injury, more than 4,000 tests, more than 6,000 medications, surgery, treatment. Uncertainty is an inherent element at every step of the diagnostic process. Remember, the diagnosis is a hypothesis based on available data. Absolute certainty about the diagnosis is unattainable. And no matter how many information we gather, how many observations we make, how many tests we perform. And remember, every doctor is fallible. No doctor is right all the time. So how does this affect our daily lives? So only accurate and timely diagnosis provide the best opportunity for positive clinical outcome, as we already said, and we strive to get there. But we are judged on very different metrics. So delivery of high quality care is being measured daily by simple scorecards like blood sugar measure, was shot a flu shot given, pneumonia shot, etc. While quality care is much more, means thinking broadly, making judicious decisions with limited data day after day, neither overreacting nor being blasé. So as we can see, this whole diagnostic process is very complex. How does that actually affect us in pediatrics? So what are pediatric specific difficulties in diagnostic process? First of all, children in general are very healthy population. So there is a low disease burden compared to adults. Then we deal with developmental considerations. So different ages bring different risk, different approaches are needed, different examination skill, different communication skills, and then add to that children that are developmentally diverse, children with medical complexity. There is a lot to think about. And then the other thing is that children often present with very common undifferentiated symptoms like fever, abdominal pain, that are common and time-limited condition. It's much more common that's viral illness, or there is a minor injury, there is a bronchiolitis or asthma or constipation, rather than something more serious. And in general, it's all far more likely to be benign than serious. So fever in children is more likely to be viral illness than sepsis, and abdominal pain is more likely to be constipation than appendicitis. The risk of missing rare but serious condition within a generally healthy pediatric population creates significant stress in diagnostic process for physicians. As Dr. Snelson said, the chances of serious disease in children is low. However, the consequences of not treating specific illnesses are devastating. Furthermore, pediatric diagnoses often don't have a single specific test. Rather, it's a synthesis of available data. Think Kawasaki disease, JIA, bronchiolitis. And then obtaining tests are placing children at certain risks that are less needed to be considered in adults. So getting CT fluoroscopy exposes them to radiation, possible further malignancy, doing an MRI requires a sedation with its own risk, getting the blood draws are putting them through more suffering and pain. So we need to balance all that. And another thing is that pediatric testing recommendation by American Academy of Pediatrics Initiative of Choosing Wisely advises against low yield testing in the common presentation. So like 5 main things in choosing wisely is don't x-ray every bronchiolitis or first time wheezing, don't x-ray constipation, don't do the viral testings for URI, don't do CT scan for febrile seizures or for minor head trauma, don't do labs in patient pediatric population that are waiting for psych placement. These are all very good and valid recommendations, but there will be a patient that presents with one of the common things and that has something uncommon that could get missed. Another thing to think about is parents' desire for reassurance. They might push for more testing, and also clinicians' uncertainty, especially clinicians that don't deal with children, might lead to over-testing and unnecessary harm. That's another aspect of diagnostic errors. So like looking for hypoxia in well-appearing infant, or getting tests that are not really necessary, and then getting those panels and getting abnormal tests, and now doing more testing to prove that that first one was actually incorrect. So that those are all specific issues that we deal in pediatrics. So how do we analyze diagnostic error? How do we figure out why do they happen? We need to explore and open a window into the medical mind while looking in diagnostic error. We need to ask a question: why doctors fail to question their assumption, why their thinking is sometimes closed and skewed, why they overlook the gaps in their knowledge. Most of the misdiagnoses happen due to cascade of cognitive errors, around 80% of them. Only 20% of diagnostic errors happen due to no-fault errors or system-based error. So I'm going to spend more time on talking about cognitive errors. Just to mention, no-fault errors are the one that diagnosis objectively couldn't have been made because the symptoms were atypical or absent, or the patient presented early in the disease, or patient misrepresented the symptoms and information. While the system-based errors are errors based on policies, procedures, inefficient processes, coordination issues, technical difficulties in lab, radiology, difficulties with communication, teamwork. But because most of the misdiagnosis happens to cascade of cognitive errors, we are going to talk about that more. So cognitive errors is a big bucket where faulty knowledge is around 3%. Faulty information gathering, so like missing things in history, on exam, ordering not appropriate test, diagnostic imaging is around 14%, while faulty synthesis of available data is the most common cause of cognitive errors. The faulty synthesis involves faulty information processes and faulty verifications. So how doctor thinks, how do they put those patients' information together into the diagnosis? Doctors goes through the cognitive process that's called clinical reasoning. Clinical reasoning is the cognitive process necessary to evaluate and manage patients' health problem. Occurs within physician's mind and involves judgment under uncertainty, consideration of possible diagnosis to explain patient signs and symptoms, and consideration of benefit and harms of diagnostic testing and treatments, and patient preference. And then even though this whole process happens in doctors' brains, it is facilitated or impeded by work system. That's where the system-based error could happen. So how doctors think? The theory that explains how we think, it's called dual processes theory of thinking. And it's not unique to only medical professions. It applies to all aspects of scientific life. I will discuss it more as it applies to medical diagnosis and medical decision-making. So system one is non-analytical, it's intuitive, fast, unconscious, contextual, experience-based, automatic pattern recognition. While system two is analytical, deliberate, slow, logical, critical thinking, conceptual, with heavy use of working memory. They've done MRI investigations, so people, when they are going through these processes, those two systems actually activate different areas in our cortex. Both systems are prone to cognitive biases and diagnostic errors, and errors cannot be contributed solely to one or the other system. It kind of feels like, yeah, this system one is the problem, but it's really both systems are prone to biases and diagnostic errors. So let's talk about system one. And to address that, we need to talk about heuristics. Those are learned shortcuts that all physicians use to improve efficiency of diagnostic process. Basically, this is the first thing that comes to mind. It's based on pattern recognitions, the key cues to patient's presentation that coalesce into a pattern that is recognized as a specific disease or condition. Those are mental shortcuts that are used when we assess unknown patient, and we must work quickly. Like think ED, private office, patient is deteriorating. This pattern recognition system is 10 times more efficient than hypothesis generation and testing. It is foundation for all mature medical thinking and can save lives. With the caveat that it works when it's used by experienced physicians who have spent countless hours seeing thousands of patients, learning from mistakes, learning for patient perfecting this process of rapid judgment. System one is also called clinical intuition. It's a complex sense that's refined over years by listening to stories from thousands of patients, examining thousands of people, and remembering when one was wrong. Competent doctors recognize and remember their mistakes, misjudgments, and incorporate those memories into their thinking. When leading to diagnostic errors, heuristics are referred as cognitive biases. So what about system two, or detail analysis? The thinking involves detailed analysis of all available data and categorizing them into known entities, creating a detailed differential diagnosis of diagnostic hypothesis. System 2 systemically analyzes differential diagnostic hypotheses, eliminates or includes them based on gathered data until coming to diagnosis. Think about these clinical pathological conferences that we read about in New England Journal of Medicine, morning reports, medical students, exercises, case discussions, presentations. So system 2 is employed when confronted with unfamiliar problem, a difficult decision, contradictory evidence, requires effort, understanding, and ability to engage in hypothetical deductive and/or inductive reasoning. The study of the diagnostic process actually showed that predictor of diagnostic success was occurrence of the correct diagnosis as a hypothesis early in the encounter. It was found that 96% of physicians who made a correct diagnosis had that as a hypothesis early in an encounter. 85% of physicians who missed the diagnosis never mentioned it as hypothesis during the encounter. So when system 2 fails, it's usually due to inadequate knowledge base and poorly developed differential diagnosis. It is essential to achieve balance while using dual process clinical reasoning. Effective medical diagnosis involves two distinct thinking models, complementary in many aspects and acting in harmony to deal with limitations of human memory. Errors happen due to failure of this complex interaction between normally adaptive heuristics and usually adequate knowledge-based clinical reasoning. What can we do about this to make sure we don't run into these cognitive errors? Significant reduction in cognitive errors can be accomplished when using both thinking strategies while evaluating a patient. Clinician needs to be able to switch backwards and forwards between the two thinking systems as a means of cross-checking their decision-making process. System 1, think of the first that comes to mind, but then involves system 2, think of other possibilities. How do we achieve this regular activation of both systems and keeping check and balances? Introducing the metacognition, which is a process that connects system 1 and 2. It's a self-reflection on the process of thinking and self-regulation and monitoring decision-making. It's purposeful activation of system 2 problem solving, prompting more analytical examination of available data. It's very important skill of mature physician. They check and balance their thinking process, especially when data don't fit or there are red flags that are present. Another thing to worry about is an attitude problem that we as physicians face, and it's overconfidence, which is general belief that we are better than we really are. It's a misplaced belief in the efficacy of one's thought and actions. They surveyed physicians and they found the attitude problem can cause diagnostic errors. 94% of academic physicians rate themselves in the top half of their profession. They had difficulty recalling any errors they made. So 9 out of 10 people disagree with my ideas. That means 9 out of 10 people are wrong. I just couldn't resist this slide. The dual process theory further evolved, and introduce another concept, and that's the theory of adaptive expertise. It complements the dual process thinking theory and explains how efficiency and innovation is balanced in clinical problem solving. So clinical problem solving is a dynamic process, and with experience, it grows further. The theory of adaptive expertise is grounded in ability to engage in both types of thinking, intuitive and analytical, while creating new knowledge. The theory of adaptive expertise recognizes two kinds of experts. One is adaptive expert, who uses knowledge, learned experiences, reflection, and conceptual understanding to create novel solutions, who recognizes changing conditions, and who adds to knowledge base reasoning capacity and ability to solve cases. In contrast, routine experts, they use pre-existing knowledge, solve routine, familiar, uncomplicated problems with lack of experience, lack of self-reflection, inadequate knowledge, failure to recognize when heuristics are becoming cognitive biases. So now that we learned about diagnostic errors and how they happen, we need to tackle a problem of how to prevent them. So definitely preventing diagnostic error is much more complex than building safety checks into healthcare system. It is essential to achieve balance while using dual process clinical reasoning thinking and to apply metacognition. Over-reliance on either system could cause errors. When data and clinical findings do not all fit neatly together, one needs to use creativity and imagination rather than adhere to the obvious. And that's where adaptive expertise and adaptive experts come in. We need to facilitate humility, self-awareness, professionalism, and avoid overconfidence. Knowing when one doesn't know requires sophisticated knowledge. What we know is based on modest level of understanding. We need to be ready to challenge what we know the moment new data suggests our knowledge might not be correct. So hopefully we now recognize we have a problem, difficult one. What are the concrete steps that we can undertake to make it better? So a Society of improve diagnosis in medicine in 2018 came out with a goal that's defined in statement, act for better diagnosis. So by working together, the accuracy, communications, and timeliness of diagnosis can be improved. One of the things we can do as clinicians to prevent diagnostic errors is to ask ourselves questions. Even when thinking that we have the answer, we need to generate a list of alternatives. Ask yourself a question. What else could it be? Is there anything that doesn't fit? What am I missing in this case? What would be the worst thing to miss? Was I affected by being hungry, angry, late, tired, mnemonic halt? Remember, every diagnosis has a different differential diagnosis. So to prevent diagnostic errors, we can ask a question: what else could it be? It safeguards against several cognitive biases, one of it being premature closure. So premature closure is when we shut off thinking before there is sufficient evidence to support particular diagnosis, before that diagnosis has been fully verified by data. When diagnosis is made, the thinking stops, or counting chickens before they hatched. Another thing this question, what else could it be safeguard against, is context error or framing effect. It is the clinical thinking gets distorted by the background perception of a case presentation. The framing of the clinical scenario influences the way patient is thought about. It's a very frequent situation when the transfer of care from handoff from ED to inpatient, PCP to ED, daytime to nighttime shift, nighttime to daytime shift, for example. Oh, this patient is fine, mom is just very worried, that's why it's been admitted, it's a social admission. And then as the time goes on, the child is getting worse, the new data come and it's not being acted upon due to the context framing effect. Another thing that asking question, what else could it be, can safeguard against is availability bias. Availability bias is really the last bad experience. What is most available in one's mind strongly colors thinking about the new case that has some similarity. So misdiagnosing meningitis, now everyone who has a fever has meningitis, or finding foreign body that's causing wheezing, now everyone's getting the chest x-ray because it could be foreign body. Or in the middle of bronchiolitis season, everyone has bronchiolitis and we miss myocarditis. It's basically a tendency to judge the likelihood of an event by the ease with which relevant examples come to mind. Another thing that we, with thinking what else could it be, we can safeguard against bias called zebra retreat. Zebra retreat is when the patient presents with features of a rare diagnosis, and but doctor is shying away from the rare diagnosis. Usually doctors who hunt zebras are often ridiculed and said to be show-off. And often those tests are highly specialized, hard to perform, and expensive. Frequent reasons for reverse retreat bias is lack of time, limited resources, underconfidence, peer pressure. Another set of questions that we should ask that can help us prevent cognitive biases is there anything else, anything that doesn't fit? So that can safeguard against anchoring bias. Anchoring bias is when physician focuses on a specific, vivid, prominent feature or presentation very early in a diagnostic process, and then doesn't consider multiple possibility, doesn't develop differential diagnosis, quickly and firmly latches onto a single diagnosis, fails to adjust when presented with new information, and it basically ignores important differences and comes to incorrect diagnosis. Another thing that this question, there anything that doesn't fit a safeguard against is confirmation bias. And those two, when go together, is very dangerous. So confirmation bias is when attention is drawn to data that support the presumed diagnosis and minimize data that contradict it. Its tendency to seek data to confirm diagnosis rather than refute it. Another thing that same question can safeguard against is diagnosis momentum. That's a bias when particular diagnosis becomes fixed in a physician's mind and is not questioned anymore despite incomplete evidence. Once diagnosis labels are attached to patients, they become stickier and stickier. Diagnosis basically rolls like a snowball, becomes bigger and bigger in our mind, and it sticks to the mind. And it's a tendency for diagnosis to get established without particular evidence. So, like common examples, we all heard about it. Vomiting, child comes with vomiting, it's gastroenteritis, gets in home with after rehydration comes back. Again, it's gastroenteritis, sent back, and then it turns out that it's head bleed or it's tumor. We all heard those stories. Another bias that can be fight against with this asking yourself, is there anything that doesn't fit, is search satisficing. Or satisfaction of search. This is a bias where there is a tendency to stop searching for a diagnosis once something is found. Finding something is satisfactory, but not finding everything is suboptimal. Basically, when we find a major thing, we stop looking for more. So there is a case described where an 18-year-old came with like multiple stab wounds to chest, arms, head. Multiple physicians saw the patient CT, chest, X-ray, addressed the chest wounds. Patient got better, sent home, and then 5 days later came back with like vomiting, headache, fever, found to have a brain abscess from missed penetrating injury to the head. So how could we further prevent cognitive biases as a sort of diagnostic errors? We need to go through process of debiasing, which is basically improving awareness of the effect of cognitive bias on diagnostic error. It's not easy. Many clinicians are not aware of the presence and effect of their unconscious cognitive biases on diagnostic process. There is no single strategy that would work on all biases and requires multiple intervention, lifelong maintenance and commitment, and constantly applying metacognition. We need to encourage learner in a process to regularly and frequently challenge their clinical decision reasoning. We need to develop and maintain educational strategies that promote clinical thinking and metacognition, promote the ability to engage in purposeful and self-regulatory judgment. We need to learn to judiciously activate analytical thinking model to override intuitive mode when needed. Clinicians need to develop a habit of regularly and frequently surveying of their intuitive behavioral and self-reflection. We need to develop culture of safety. One of the things that we can do is change the term of diagnostic errors to a term that doesn't imply failure. So we can call it more like misdiagnostic opportunity or diagnostic learning opportunity. We need to create feedback mechanism to inform physicians of their diagnostic performance. There is a recent initiative called Loop Project, where the feedback was given to physician on changes in diagnostic reasoning after the handovers. And it was found that the significant major change to diagnosis from admission through toward discharge happened in 12.7 major diagnostic 12.7% of the cases. And the learners and learners and all the physicians involved in that project expressed the satisfaction by getting this feedback. What are educational strategies that we have available to use? As again, we need to develop educational curriculum that provides training in critical thinking. So one of the things that we can do are apply diagnostic timeouts. Basically, ask yourself, was I comprehensive? Was I affected by being hungry, angry, late, tired? What is the worst case scenario? Or we can develop diagnostic checklists, which are this is a checklist that we should do every single time we encounter the patient. So do your own history, do your own exam, develop the differential diagnosis. Remember that every diagnosis has differential diagnosis. Then we can do a structured case gap analysis going through the process of analyzing case. Then there is something called red team, blue team challenge that can be entertained with learners, where blue team presents the case and presents their working diagnosis, while the red team in respectful way challenges that diagnosis and come up with more options. And then another thing that was developed in Australia is initiative Take Two, Think Do. So you basically take 2 minutes to think about your diagnosis when there are certain red flags and when things don't fit well. You think, what else can it be? You go through all these questions to address your possible cognitive biases, and then you bring a senior physician in, you ask for second opinion, you ask for consult, and that way you safeguard against diagnostic errors. We need to regularly assess learners' progress and give them feedback. Society to Improve Diagnosis in Medicine develop a tool, which is called ART, Assessment of Reasoning Tool, that can be used in educational curriculum to address the development of learners' reasoning. So I will stop here because I can talk about this topic for much more, and especially about educational strategies, potentials to develop curriculums for faculty, for residents, for medical students. My hope after this round, grand rounds, and is that you will find that this is possible to respond to the patient safety imperative call that's made by National Academy of Science, Engineering, and Medicine in 2015 in their report Improving Diagnosis in Healthcare, which says that improving the diagnostic process is not only possible, but it also represents a moral, professional, and public health imperative. Thank you for your attention.
Thank you so much. That was a great presentation. There was one question in the chat and some discussion of it, and that is regarding the documentation when you're discussing the different differential diagnoses. So some coders discourage using phrases such as most likely, favor diagnosis, or probable diagnosis, and they prefer one to commit to a diagnosis. Um, are there any society recommendations as to how to address the diagnostic uncertainty while still keeping the coders and billers happy?
Yes, there is actually there is a recent study that addressed that and actually marked the diagnosis and undecided and as a possible, and actually followed it through the admission process. And it was actually found that the diagnoses that were marked as uncertain, those patients have actually a longer stay and higher cost than straightforward diagnosis. So actually the Society of Improving Diagnosis in Medicine does encourage people to discuss in their assessment of the most likely diagnosis, but also differential diagnosis with very specifically explaining why are you doing tests and what you're trying to find out, rule in or rule out with those tests.
Okay, thank you. That makes sense. I don't see any more chat or any more questions in the chat. So I think with that, unless I hear anything else, thank you very much. This has been great, and I appreciate having some actionable items. Thanks.
Thank you. Bye.